So I think what I was hoping, Justin, to have a conversation about, as we talked about earlier, was just sort of the updated science, what you've seen in MiSight, the second 3-year data that you can talk about, and then some of the nuances of what we're seeing in terms of longevity based on the evidence of MiSight and how powerful it is.
Yeah, totally. So, at the start of year 4, after the first 3-year randomized controlled trial, you had the control group, which was older now. I mean, they both were older, but the control group had more myopia and, of course, then longer eyeballs, right? And so the question was, would they have a response? Would they also get treatment efficacy for years 4, 5, and 6? And thankfully, the answer was yes. The whole second phase was about comparing the original treatment group to those that started treatment 3 years later, and they were essentially parallel.
So if we can kind of go back a little further, because you did exactly what I asked you to do, is to jump in at the updated version. But let's assume that I know nothing about the first 3-year version.
Yeah.
Okay? Hello and welcome to the Gross World Podcast on iCode Media. Today I had a great conversation with Dr. Justin Kwan about the nuances of the MiSight study, both the 3-year data and 6-year data, and then what we're going to expect in the next few months on the 7-year data. So there's a lot of fun. I always have fun talking to Dr. Kwan, and I always learn a whole bunch. So please enjoy our conversation. And as always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. So in the first 3-year version, the summary points was we reduce axial elongation by what percent and myopia by what percent.
Yep.
And then you had after that 3-year group, you let the control group do something else. So kind of take me from that beginning and then move on.
Sure. Yeah. So the MiSight study, 4 clinical sites: Singapore, UK, Portugal, and Canada. The control group progressed just like kids in the Achieve study, which is, we always focus on that because people will say, well, these international kids aren't going to be like the US kids, but they grew exactly the same, 0.62 millimeters in 3 years.
So you can match what was happening in all these other countries to a study that was happening in the United States.
Correct. And so these kids were 8 to 12 years old when they started. Half were randomized to MiSight, half to ProClear 1 day. None of these kids had ever worn contact lenses. Of course, they couldn't have passed myopia treatment. And the first 3 years ended with a 59% average efficacy for cycloplegic spherical equivalent. And 59% usually doesn't mean much, right? It's like what? So I think it's helpful to think of a -2 10-year-old, which was the average. MiSight ended up 250, ProClear ended up 325. So that 3/4 diopter difference
over 3 years.
Over 3 years, yes, is what that 59% amounted to. And some people might say 3/4 diopters is not a heck of a lot, but remember, every diopter matters, and that compares very well to other studies. And I try to think back to like a systemic disease like hypertension. And of course, lisinopril as an ACE inhibitor reduces blood pressure by 20%.
Right.
So 59% is pretty darn good.
Yeah.
Yeah, pretty fantastic there.
And so then the second part of that, where we're kind of getting more updated data for this next 3 years, the first component is we're thinking we can now, instead of saying we can spare a diopter, we're now closer to 2 diopters in evidence.
Yeah.
And then there was sort of this, the patients, as you were saying before, who were in the control group were now allowed to be in the treatment group.
Yes. Yeah.
So let's talk about those two things.
Yeah, so we'll start with the second first, is that when the control group got refit from ProClear to MiSight, they also achieved a very nice slowing of their progression. And we typically try not to go, the prior year's progression to now the current year's progression, because, well, we lost our control group, which was the ethical thing to do. But it was comparing to the kids that were in MiSight originally, and it was extremely parallel. It was 0.16 diopters year 4, then 0.14 diopters year 5, and actually almost 0 diopters for year 6. So they were naturally slowing down when they got older. And so maybe MiSight wasn't really necessary in that year, but it's always nice to have no progression. And this is very well-controlled, cycloplegic, of course.
Do we have any other studies that have looked at progression over 6 years? Just natural progression over 6 years, that period of time?
Yeah, those prospective longitudinal, I think what's typically referenced is the Donovan paper, where they looked, I think, from 7 to 12-year-olds on Europeans and Asians in single vision glasses. So yeah, no treatment there. And actually, yeah, the untreated progression was a little more rapid than our MiSight control group, but it follows very well. And we always say the younger they are, the faster they progress. It's a very easy to remember thing. And I think it does drive the urgency for doctors to not just be like, oh, I'll see the 7-year-old in a year.
Well, I present a case on that. Actually, I presented a case yesterday at the Global Contact Lens Symposium that was that. It was a 13-year-old patient. It was the first time I saw her, but when you look at her prior spectacle RX, she had progressed a diopter and a quarter in one eye and a diopter and a half in the other in 1 year. Based on the first time I saw her. And you start to do some of the analysis, like the analysis it sounds like I'm not saying it right. The analysis of if we start treatment now, we can spare. So it was like over 3 years, we could spare about three-fourths of a diopter. But had we gotten to her just 1 year prior, it would have been an additional, in theory, an additional three-fourths of a diopter, right? So now you're talking real numbers.
Yeah, I think it's kind of like you have the ability to like apply the brakes, and then as the car is slowing down, they're naturally slowing down too. So it's almost like you're coming to that full stop.
But it's just always challenging because I think there's this reaction for us to be like, well, we'll have a serious conversation, but not quite as serious with a parent who's kind of like, well, they've only progressed a quarter diopter, maybe a half diopter. So you probably should really think about this. There's this natural inclination for us to do that, right? And then, but then you didn't start it because they only progressed a quarter diopter this year. But now it's a diopter.
And you can't get that time back.
You can't get it back.
As another doctor said, you can't undo what's been done, and now you're staring at whatever -4 and I think that reminds me that while average age of stabilization is age 16. You're going to treat a 16-year-old -4 different than a 16-year-old -1. So I think that all plays in. And as you said, you got to kind of read the parent, but be confident with your prescribing, right? And just take the whole clinical picture into account.
I want to revisit why this matters again, because I've seen a lot of, scuttle in social media about myopia controls or myopia management is just it's not that big of a deal. We don't really have to focus on it, and it's overblown. What would you say to that?
I mean, if they have taken a picture or look at the retina, it's clearly anatomical changes, and we know how those stories tend to end. Not everybody that's -10 gets myopic maculopathy, but there are some -1s that get myopic maculopathy. So I think if we do our part, I mean, there's countless analogies, right? Smoking cessation, right? Not everybody that smokes gets lung cancer, but do you want to reduce the risk? Sure, right? Do you need to reduce the risk harder for somebody that's COPD? Absolutely, right? And there's just so much, like in contact lens world, we talk about like microbial keratitis and, you don't need to wear your seatbelt.
Right.
But you should. and I think those things are, I don't understand the disconnect of why we don't look at this as a disease. And you can only blame the centuries of thicker glasses and updating prescriptions, but there was a turning point that we see ourselves as medical, providers. And this falls into the definition of disease, and this is children, for goodness sake. Like you can't. We've been on some parent focus groups, Chris, and it's like, even the parents are said, we can't not live with ourselves, but we can't be in a place where we regret or what if we didn't, or, they do have that in their mind. And I think it's important to hear out these parents that when they were shown, not even like a scary diseased retina, they were just shown that the schematic of a normal eye and a longer eye. And they're like, I don't want that longer eye.
Right.
And sometimes that's all it takes.
Right.
And if a doctor can't even rationalize that, and a parent that's a layperson can be like,
Yeah.
I feel like, wow, did we really let the public get more educated than the doctor?
I wonder if we've been browbeat to some degree as a profession to think of refractive conditions as just not that significant. Like it's sort of this like minor because of who pays for a refractive condition versus who pays for another medical condition.
Yeah.
That in our minds we've just allowed the payers to browbeat us into thinking, well, refractive conditions, those aren't as serious. That goes to the vision plan. Right?
I think there's an element of that.
I wonder how much of it exists because then when you start thinking about, even I, when I'm presenting on it and I talk about this idea that when you're seeing a scleral crescent in a myopic patient, and even in a mildly, if I'm noting a patient that has a temporal crescent and it's a quarter diopter myope, it's intuitive for me to think that's myopic stretch, right?
Yeah.
But I would deny it for years. I wouldn't not deny it, but I just wouldn't actively like put two and two together. I was always thinking, oh, it's not really something I'm
a variation of normal, I guess.
Exactly. No big deal. But like in fact, that is a retinal finding associated with axial elongation, which is in fact a medical condition, right?
And if you could like miniaturize yourself and go into the RNFL, like what's happening there?
Yeah, exactly.
Right?
Yeah. So like you really have to consciously think about it. And when I present that information, I'll present pictures of different amounts of myopia and different amounts of even just small variations of axial elongation that you're seeing in the eye. That is a reason to monitor that patient and, I would argue, treat that patient, right? Then we wouldn't look at it any different if we could slow the progression of glaucoma, slow the progression of macular degeneration. We shouldn't look at it any different. But for some reason, I always kind of have this internal, like, should I tell people to be using this medical code when they see this? I'm like, I think I should, but what are people going to think of me if I do that? And, it's just...
Or maybe
weird.
It's also because we've begun to teach myopia management in optometry curriculum in the schools, but it doesn't live in the disease course, right?
Yeah, it's refractive.
I think maybe that's a part of it too. Yeah.
Well, and it starts to make you wonder, how many patients do you see? So I have to be honest, I don't see a ton of patients who have what I would think of as myopic maculopathy, right?
Yeah. I could probably count them on one hand in 1 year.
But they exist largely in the retina practice.
Exactly. Yeah, we lose sight of where they end up.
Yeah.
And whenever I'm speaking from the stage too, it's like I stumbled upon a Facebook support group of patients living with myopic maculopathy. And if you see post after post of, wow, where are these patients living? Who's their doctor? And they're really 51 years old as a minus 450 getting anti-VEGF. I'm like, wow, so they do exist, right?
And the anti-VEGF doesn't work like it works in AMD.
It works differently, although it's more responsive. I've talked to some retinal specialists.
Better.
Yeah.
Interesting.
Yeah.
Well, that's actually that's good news, I suppose.
It is good in a way, but
but you're always going to go down in defeat once you're in anti-VEGF. I think that's the side of it is that at some point you're gonna have scarring and likely, and it's going to impact vision at some level.
Yeah.
But I guess I brought that up because it does make me wonder. Like I get some of these patients that have they might have been, let's say, a 2 diopter myope or a 1 diopter myope, and they've got or you start looking at their maculas and their macular function is good, but they've got these kind of disruptions in their macula. Maybe they got a myopic crescent, and you're kind of thinking, well, is this early macular degeneration because I've never seen them before, or is this a product of their maculopathy?
Yeah.
So it just makes me wonder if we're not, some of those early cases, what we would consider AMD isn't myopic maculopathy, and it's just such a challenging line unless you are seeing that patient over years to know what it was actually from.
In some cases, it could be both.
Yeah. Is there what is the association? I don't know this answer, but What's the association between patients who have myopic maculopathy? Are they more or less susceptible to AMD, or does it matter?
I haven't read anything that says that it makes them more susceptible. I guess you could say, is there any oxidative stress when the tissue and the choroid is not supporting? Because we know in myopia, the choroid is thinner, it's different, and so maybe there's something there. From both a structural and physiological standpoint. But yeah, I'm not too sure of the odds ratios or, how that impacts one to the other. Yeah.
Do you think about the choroid much? Like, I know there's more
starting
coming out
to.
about choroidal thickening. Is that
Yeah.
something that's been measured in the MiSight studies?
I want to say I don't think it was, but I know that in ongoing research, like going back maybe a year, like they are looking at that very intently. And usually when I give talks, I also talk about, what things can impact the choroid in a very short term, like upon 30 minutes, 60 minutes type of time frame. And surprisingly, VR headsets, virtual reality, they thicken the choroid. So does dark mode on your phone or your device.
It thickens the choroid.
Yes, if you have white font on a black background, it actually thickens the choroid, which is a good thing. Is it clinically significant where you're like bolstering this dynamic relationship? Who knows? But it can't hurt. I mean, whenever you can thicken the choroid in myopia, that's a move in the positive direction.
And the theory behind that is that the choroid is then resisting additional axial elongation. Is resisting it, or is it artificially hardening? Like, how does that relate to?
Because it's vasculature. I'm not sure how it impacts like scleral rigidity, but I just know it's a biomarker at the end of the day, the thickness. But I think it relates to dopamine, because we know that dopamine signals the outer retina and the choroid to change, and dopamine somehow is a stop signal for axial elongation. So in that cascade somewhere, the choroid is important. It's hard to figure out.
Does nitric oxide come into that at all, as well as dopamine? I can't remember if dopamine plays a role in where that could thicken the choroid as well, right, by dilating blood vessels.
Not sure on that, Chris. Yeah.
It's just again the stuff. I think the hard part is that there's so much stuff that we know, and it feels like the more time goes on, the faster we know stuff, right?
Yeah.
But then also, again, I think the detractors would say what I think they're missing is like, well, we don't know all this stuff. Like, there's so many. We don't know how atropine works. We don't know how. We don't know exactly how orthokeratology or peripheral defocus or MiSight, how the change in that defocus peripherally works on MiSight exactly. We have a pretty strong hypotheses that have been around for a long time. They seem to make sense. And so that, I think, in a lot of cases is deterring people. But I think there's other, like, we don't know exactly how many medications we use works. We have good hypotheses. We don't know exactly. Right.
Like, how do those new glaucoma drops, beyond the trabecular mesh work, how do they fully, get to that extra level of moving past episcleral venous pressure? That's not fully understood, right?
So it's, I think the other point, if you can touch on, is, okay, well, in the future, probably the last point that I'll have you touch on today is, in the future, the data that you would think would be important to evaluate with any new technology that was going to come through. What would you say? All right, well, now you've got 6 years of data. We're going to have another 7 years to see what happens when or another 1 year when we see what happens when it stops. Okay, so that'll tell us, kind of help guide us with MiSight specifically on what we should do when we're stopping patients. Maybe, or at least inform some decisions. But then outside of that, okay, so what's the next step if there were like a spectacle lens available or an orthokeratology lens that were available? Like, what sort of things would you look for to say, okay, this is what would help me know, not just FDA approval, but outside of FDA approval, if this is going to be an option that's going to be useful to my patients?
I mean,
just in looking at the evidence in total.
Sure. I think it still comes back to axial length, and in the current past studies, understanding what are the characteristics of kids that did not respond as favorably to the treatment, whatever the treatment is. And some would define that as continued progression of a half diopter per year while under treatment. But really understand the axial length growth of course, which is highly affected by age and ethnicity. But it's coming to that place where people always say we may not need a control group anymore, just because all these data points are very tight in how kids grow in their axial length from one age to the next and older and so on. So I think any future studies are going to continue to be 3-year minimum. They're going to have a rescue treatment just like we did. And they're really going to try to understand, what happens when you stop. And then potentially maybe there's going to be a small cohort that might need to restart treatment. That's not going to be very many of our patients in practice, but I think it's important to understand like the stabilization aspect.
Yeah. I told you that was going to be the last question, but I spawned another one. So is there a sense that you have about the non-responders?
Yeah.
Is there something common about them, or because I think what's really going to be valuable in the future is to have, if there's a way that we can have really great predictive models, right? I think even for doctors to
hugely
know,
so.
You get a patient that's a -1 at 10 years old, and they're going to stay a -1. What could we know about that patient versus the patient that's a -1 at 10 years old is going to be a -8? Right? Being able to make that kind of determination, I think is going to be hugely helpful.
I mean, our field is starting to move in that genetic direction, and as we learn more about the genome and epigenetics, I think there will be some elements of that fast progressor and relating to the parents and whatnot. But to understand the non-responders and those that respond super well, like you said,
because there's not a lot of information right now that you can clearly say, this group didn't respond because of this, and this group responded because of that. You don't really know why.
We don't know. I think the non-responders have some elements where, with the MiSight, you're inducing some higher order aberrations into the system. But for the kids that did not respond, I think they continue to get a low level of higher order aberrations. Just in their inherent HOAs combined with the MiSight HOAs, it probably canceled out to 0. And we know the more aberrations, the slower the progression. So I think they probably were at a near 0 HOA. And so they probably continued progressing to some degree, coupled with, of course, the environmental, bright light exposure and all that. Probably plays in. So
that's interesting. So
it's my hypothesis.
It's as valid as any. I mean, it's just interesting because I think the more. That's in addition to the things that you said in terms of looking at studies. I think one of the things that we're going to have to turn to in studies that will be exponentially valuable is to be able to say, okay, these patients are faster responders, or these patients are faster progressors. These patients are slower progressors, and these patients are likely to be unresponsive to this treatment. Because the reality is we already do multiple treatment options that are FDA approved. And so it's going to be really great at some point.
It's personalized medicine is what we're after.
Exactly. And that's going to be kind of at some point. But I think it's probably fallacious for us to wait for that, right? Clearly the evidence tells us we shouldn't be waiting for that at this point, but it'll be great when we can do it. Well, Justin Kwan, thanks so much for being on again. It's always helpful to pick your brain.
Thanks, Chris.
You're welcome.